Well, hello everyone. Welcome and happy 2025. I think we're launching the fifth year of doing webinars thanks to COVID, but we continue to do better, try to be better. And this can't be a better way of launching 2025 than with this really exciting webinar. I believe this is the largest number of registrants we've ever had thus far. So it's because it's exciting news. Today we're going to be learning about a new device, an implant called PRIMA, and who's going to lead us in this discussion is Dr. Frank Brodie, who joins us from the University of California, San Francisco. And he's going to share all about its inception, where it is now with clinical trials, and hopefully where it's going, possibly including other IRDs, including choroideremia. So welcome. Thanks for coming today.
Thank you so much for having me. This is really a treat, and I appreciate all of you out there in cyberspace tuning in, and hopefully we can have a good discussion today and can talk about some of the things we're working on. I really appreciate you guys having me here.
What we're going to do today is, folks, I'm going to be turning off my camera and my audio, and Frank's going to be sharing his PowerPoint, talking to us about this. And as you have questions, you can type them into the chat, or you can Q&A feature. I will pose them to Frank as they come up or at the end. So we'll take it from there. Thanks.
Great. Thank you so much. All
Mhm.
right. Hello, everyone. As I was mentioned, I am a retina doctor. I'm a vitreoretinal surgeon out here at University of California, San Francisco. And I'm also a consultant for this company called Science Corporation that is bringing to market this PRIMA subretinal implant we're going to talk about today. It's kind of a return home for me. After my residency, I did a postdoc in this guy, Daniel Palanker's lab, and he was the inventor of the PRIMA implant. And so now, almost 10 years later, I'm kind of back working on it, which is really a treat for me. Let's see if I'm smart enough to figure out Zoom. I feel like this many years after the pandemic, I should be at least don't have a good excuse for not being good at it. Let's see. I just want to make sure I optimize all my little share settings here. And, huh. Now it says I have to restart. Oh boy. All right. Something happened. Can you guys see my screen? This Zoom thing is really a trip.
No, there you go.
All
Perfect.
right. We're in great shape. We'll see if the sound comes through or not. I adjusted some sound settings. Fingers crossed, everyone. So as I said, the company I'm working with is called Science Corporation, which I still think is one of the coolest names for a medical device company. What I want to talk to you today is we'll just go over some basic retinal anatomy. I'm not sure who exactly is in the audience, whether it's researchers or docs, patients, family members. So I figure I'll kind of start from the ground, and we'll just go through some very basic retinal anatomy. The focus of today's talk is going to be around the disease state of geographic atrophy, and I can explain a little bit about why that was the lead indication for this implant in the clinical trials, and how that's relevant to choroideremia. I want to talk to you about the actual implant, how it works, the clinical trials we've set up to date, and where the results are currently. I'm going to try and go into as much detail as I can, with the caveats being that some of the clinical trial data is still embargoed. A lot of this is very, very hot off the press. And that I'm not a basic science researcher. So if we really push me on some of the technical details about the electrical physiology, I'm going to fall flat on my face. But I'm happy to get back to anyone with the appropriate folks and better answers. So let us dive in here. When we think about how the retina works, let's see if we can get a video to play here just for fun. What's it doing? It's taking light through our pupil, and it's going through our cornea and lens and being projected onto our retina. And when we talk about it going onto our retina, what it's really doing is it's going onto the outer retina, right? And that's the rods and cones, which are these cells at the very bottom of your screen. And that light is being turned into electrical signals, biochemical electrical signals, which is going through that middle layer, the bipolar cells, and then being processed there up to the ganglion cells, which are now shooting it all the way down into the optic nerve, into the brain for a picture of us to see. And it's important for us to keep in mind these three layers of the retina: outer, middle, and inner. And in the literature, we usually just talk about outer retina and inner retina, but I think it's worth remembering there are kind of three jobs in the retina. The outer retina, which will take light and convert it to electrical signals. The middle retina, or the bipolar cells, which are going to process those signals, add a lot of processing power, and then transmit them to the ganglion cells, which is going to shoot it down into the optic nerve in our brain. Okay. So here it is again, kind of in a scientific schematic on its side. And let's look at that one more time. So here's our electrical current being generated. And sorry, it's kind of hard to see these little red dots, but the light is kind of now flowing from the bottom of your screen up. When they do the scientific drawings, it's always inverted. It drives clinicians kind of batty, but the light is coming from the bottom of the screen up, hitting your rods and cones. That's kicking off an electrical current, which is going to your bipolar cells. They're processing it. Now it's going out to your ganglion cells, your nerve fiber layer, and shooting down into your brain. Okay. So, what is geographic atrophy? And this is a term you guys may have heard of before or not. It is a late stage of macular degeneration. Okay. Macular degeneration is a very common disease. We'll see some slides about how common it is, but this is a very, very late stage of it where you're actually starting to lose part of the retina. Okay. Um, it progresses, it's slowly progressive. And you see there's very distinct lesions. I have pictures on the next slide where it progresses about 1 to 2 millimeters square each year, just kind of slowly taking out the outer retina. We don't understand the cause of it. There's some data to suggest it's primarily a vascular disease with a secondary inflammatory component and vice versa. So we're still, as clinicians and researchers, sorting out. But one big advance we've had in the past year or so are there two new FDA-approved drugs that are anti-inflammatory type medications. They're called anti-complement drugs, which we've know slow progression of the disease, but it doesn't actually stop it. And nothing so far actually reverses it. So if you've lost retina, we have no way of growing that retina back. And nothing is treating the underlying vision loss. So once you've lost vision in one area, if you develop what's called a scotoma or a blind spot, currently there's no way to generate vision back in that area. All we have now is new ways to slow down the progression of the disease. Okay. So what does this look like? What I'm looking at as a doctor, this is the progression going from left to right. And you can see that kind of that little yellow spot here. That's the geographic atrophy spot, and these little flecks of it kind of odd here. And it can come on of all short shapes and sizes. We have all different patterns, and we try and predict which pattern is going to grow in which way and what rate. But we have some insights into that, but I think a lot of it is just kind of guessing the shadows on the wall. And then you can see this lesion growing over time, and these spots kind of now coalescing into one big geographic atrophy area. And this is right in the center of the retina. We have a zoomed in shot here, but pardon me. This is the optic nerve off to the side. Here are the arcades. This is their macula. This is very different than choroideremia, right? Where everything kind of starts peripherally and works its way in. In macular degeneration, you start right in the dead center and you kind of work your way out. And it doesn't go out as far as it does in choroideremia. This is really a macular disease, age-related macular degeneration. But unfortunately, that's where our highest acuity vision is. So as you can imagine, this type of picture here on the right is really devastating. This could be a 2200, 2300 patient. And even though they have peripheral vision, they can't read, they can't recognize faces, they certainly can't drive, can't watch TV with that eye, things like that. So it really can be devastating as terms of quality of life and function. And it just slowly marches along. And you'd say, well, Frank, how long does it take to get from this left side of the screen to the right side of the screen? As I said, it's about 1 to 2 millimeters a year, but everybody's a little bit different. And we don't have a great way of predicting it yet. There's a lot of work being done on being able to look at these first couple images and predict what you're going to look like in a year and 2 years, etc. But some folks will go fast and some folks will go slow, and it can be a little stepwise function. So it's a frightening disease process, especially since we have no way right now of stopping or restoring vision. And so if we're going to look histologically, this is the side view of the retina of a retina that has geographic atrophy. And here in the center is that area of atrophy. And you can tell here you've got the outer retina intact where there's no atrophy, these outer retinal layers, okay? And then they just kind of fall out in this area of atrophy. Your inner retina, much like in choroideremia, is preserved, and you've just lost your outer retina. So that's a big similarity between AMD and choroideremia, is that your inner retina is very well preserved. The functioning of those middle retina cells, the bipolar cells, the ganglion cells is still there. That anatomy looks good, but you've just totally lost that outer retina, your RPE and your photoreceptors, okay? So this is a big deal. If we think about the whole US population with AMD, all flavors of AMD, it's about 20 million people. It's huge. And then, let's see if I can click and make this thing go forward. There we go. Now, only about 1 million people, which is still a pretty darn big number, have this geographic atrophy. But then if we're going to talk about the people that are going to be candidates for the device I'm about to talk about the PRIMA device and the kind of vision it can restore. This is really going to be for people with a very, very low vision. Okay, these are people that have large geographic atrophy lesions. They have disease in both eyes. Okay, so it's really massively impacted their function. You can imagine if you have one very good eye, you can compensate pretty well. But if you have both eyes are very affected, it really limits your function. And here we're talking 25, 50,000 people. Okay. But what's important to remember is in the next 15 years, these estimates on 2040, we're seeing a 2 to 4 time increase in all these. Okay. So this is really a major public health issue. And we need new therapeutics to combat this. So let's get to the meat of this thing. Let's talk about the implant here a little bit. So the PRIMA implant is what we call a photovoltaic device. And what that means is that's like a solar cell. When I explain this to people that I just kind of meet, I say, think of it like a solar cell. What a solar cell does is it turns light into electrical current. That's why you have them on the roof of your house, right? Powers your house. Light into electrical current. Let's think about what our photoreceptors do in our eye. It turns light into that electrical current that feeds the bipolar cells. So fundamentally what this implant is 378 little tiny miniature solar cells, each 100 microns in diameter. Okay, so teeny tiny, all put together on this chip that can act like photoreceptors in your eye. And this is a nice scale picture showing how big the chip is on a penny. It's all made of silicone. And what you do is we can just implant it here. If we think about, let's just go back. If you've lost all these cells, right, it's geographic atrophy. I have no way of initiating that visual cascade. Remember that other slide where I showed that electricity flowing from the outer retina and these cells into the bipolar cells, into the ganglion cells? In geographic atrophy, you've lost these cells. So there's no way of starting. There's no way light can interact with your retina because you lose that first step in the cascade. Now, when we replace it with the PRIMA implant, we can restart that visual cascade. So now light hits the PRIMA implant. It kicks off electrical current, and that's what a solar cell does. Kicks off these little electrical currents, dings the bipolar cells. They can then process that information and send it down the neural signaling cascade down to ganglion cells in your optic nerve into your brain. So it can generate an image that way. You're restarting the visual cascade and taking advantage of all the processing power. Here you go. All the processing power in these bipolar cells. There have been several other kinds of artificial implants that have been tried. And a lot of them sit on top of the retina, which would be down here. And they send electrical impulses right into your ganglion cells. Okay. And it works. It's remarkable what a lot of those implants have achieved, but you do miss out on all the processing these bipolar cells do. And you see that difference when you look at their visual results. They're not getting what, is commonly referred to as formed vision, or, you could tell numbers, letters, that kind of thing, because you're just missing out on that processing power. Those are nervous signals. So you've got this little chip here in the back of your retina. I'm going to show you how it goes in a second, but that's just part of the whole system. What you need is something that's going to stimulate that chip. And what they use is infrared light. And you may be thinking, well, why do you need infrared light? Why not just let the ambient light come in, signal that thing, and you don't need this kind of bulky headset and all this stuff. It turns out you need to generate the electrical signal on the photovoltaic chip. It takes more energy. And you don't want to shine a bunch of really bright light into the eye because remember, these patients have all this peripheral vision that's still intact. Okay, and you don't want to interfere with that. That's helping them navigate the world. And so what you want to do is you want to be able to selectively stimulate just that chip without interfering with the peripheral vision, the natural vision. And so what you do is you wear this headset. It's got a little camera that looks straight ahead like at this R, okay, dead center, that would line up with where the chip is on the retina. And it just sends some infrared light onto that chip, stimulating. I'll show you a video of that in a second to kind of hammer the point home. But the point I'm trying to make is about the reason you do infrared light is now the rest of the retina can perceive the rest of your surroundings around you. And there's been some really nice work showing that the prosthetic vision from the chip can integrate beautifully with the natural vision in your periphery. And the person kind of perceives it as just one montage of all their vision. So let's see what this looks like. These guys put together this really cool looking animation. Let's see if I can fire it up here. And I think is really slick, far beyond my computer abilities. So here it is. Here you've lost your outer retina, right? That was those blue cells disappearing there. Here's the implant surgery. You go in, and this is a procedure called vitrectomy, where you remove all the gel from the inside of the eye. It's a standard retina procedure. Here you've lifted up the retina. You put a little bit of fluid under there to access the subretinal space, the space underneath the retina. Here's this fancy injector these guys developed. You can inject the chip there. You then flatten back out the retina. You scooch the chip over to the center. And so now it's here. It's taking the place of that outer retina. Okay. So now when you go and you want to look at the clock on your stove, there's your scotoma. You put on the glasses. Now it's sending information for what was in that scotoma through this infrared light onto the implant, and it's kicking off the signals. Cool video, I think. Okay. And so here again are those glasses. Here's the front-facing camera, and there's a projection that projects infrared light back onto the chip. And here's a pocket processor, right, that has the data, has all this stuff. And as you can imagine, now that you have digital vision, you can take advantage of all those things, right? You guys have camera phones or digital cameras. You know that you can play with the brightness, you can play with contrast, you can zoom. There's all sorts of stuff you can do once you're using digital imaging. And so we let the patients with with this device take advantage of that. And so they can change the brightness, they can change the contrast. There's special settings if you want to read letters, there's special settings if you're looking at pictures, there's, you want to look at faces. It's really incredible digital processing that these guys have baked into this device. Um, I have a surgical video coming up and a bunch more data, but I don't know if I want to take a quick break and see if there are any questions, because I've gone through a lot, and just any kind of basic questions about the system. I just don't want to lose people.
Yeah, no, there isn't any right now, Frank. However, just when you that those videos are crazy. Pretty cool. As you're going to be taking us through, oh, there is a question that just came in.
Yeah.
However, though, but if I'll just finish what I was going to say, for the people that don't see very well, if you can kind of describe what the videos are going to be showing, that would be awesome.
Absolutely. You want me to go through that video again that we just showed?
I don't think so, unless somebody chimes in now and says yes. I think we're good on that. Diane, oh, I won't say the name. Somebody in the queue is asking, what is the typical age for this procedure?
So, you'll see in our trial, patients were older, with our lead indication being age-related macular degeneration. Kind of the tip off there is the age. The average age in the pivotal study was about 79 years old.
Okay.
There's a reason it couldn't go into someone much younger. It just that is when these patients kind of qualified. I think the entrance criteria for the study was 65. But there's nothing inherent in the technology that would say it has to be in folks in older age. In fact, we're looking at some indications down the road where it would go into younger patients who have inherited retinal diseases. Um, we
Mhm.
we are still understanding the very long-term effects of how this behaves in the eye over decades. I think the farthest out we are now is 10 years from the first patient or so, and it seems to be doing well, and it's totally biocompatible, and we're not seeing issues there. Um, but I couldn't answer you, how does this thing look at 50 years later in a patient? We don't know. We know about a decade out, and at a decade it looks great. And I guess the only other piece of data we have to support that is in some of our patients who unfortunately passed away during the study, um, not from the chip, just from other causes. We were able to get their eyes post-mortem and look at it, and we didn't see any kind of inflammation around the chip or any bad reactions affecting the implant, which further bolstered our confidence that this thing could be a long-term biocompatible thing. But that is one issue we're obviously continuing to explore. Is that helpful?
It sure is. And 10 years is quite a lot of time, to be honest, that you've been
Yeah,
able to have this data. So we do have a couple more questions. So let's do it this way. There is a request to show the video again. So if we could back up and you could explain it maybe a little bit, that would be
absolutely.
awesome. And then of course the questions that you knew we'd be asking, you can answer later on. One would be, how is this device connected with choroideremia? And the process of being tested and the price. Um, and then the other question is it removable? So if you want to take those as you want now or later on, however
Yeah,
you'd
let me do
like.
them now before I forget them all, and you remind me as I go.
Sure.
So, if we think about choroideremia, and the disclosure is I'm not a choroideremia expert. We have really great choroideremia doctors in the community, which I'm sure you guys all know. But I send my choroideremia patients, I can't even say the word, to those experts because I know it's a complex disease. Um, but we know that the outer retina and the RPE and the underlying, choroid capillaris is what's affecting choroideremia, and the inner retina, to the point I was making before, is well preserved. Um, so since this only replaces the outer retina, it actually could be a very good theoretical fit for choroideremia if you just look at the anatomy, right? Because in choroideremia, your middle and inner retina are intact. This supplements your outer retina. It obviously does not need a blood supply, so that's a huge opportunity in choroideremia for this. The challenges I see are, you know, the central vision where we're really focusing on this is affected last in choroideremia, right?
Mhm.
It's very very late in the disease stage, and patients actually retain very good vision for most of their lives. Obviously, there's variance, but so unfortunately, the way we're thinking about this now is it wouldn't be something you could use early on, but maybe very very late in the disease stage. Um, the other thing is if you think we're just giving you those 2 millimeters of vision, um, and so it's like looking through a little tiny pinhole, which is obviously a huge help when that pinhole is dark and you need it, but you need to be able to kind of orient to the laser. And so one challenge, and we've got some strategies on how to deal with this with eye track and other things, is we do find that peripheral vision in our AMD patients is helpful to orient and make sure that eye is kind of lined up with the laser beam so the laser can hit the implant and generate the image. Um, I'm hopeful with eye tracking we can overcome that, and we can use this in patients who have very limited peripheral vision and things like choroideremia, retinitis pigmentosa, all these other diseases. Um, but right now, with the current generation, we do see that peripheral vision is very helpful in orienting towards the implant, if that makes sense, the light stimulus towards the implant. Um,
Mhm.
eh, well, sorry, what were the other questions? That was and is
Um,
it clear on
and
the
you know,
choroideremia analog
you
thing?
work with Jackie Duncan, don't you? Is that the
Yes.
primary
Oh, yeah,
implant
yeah. She's
for?
wonderful.
Yeah, yeah.
She's
She's
she
been to our
gets on
conferences
my
before.
pages. Yeah.
She's great. The other one associated with this is the process of testing and the price, and is it removable?
Right. So, process of testing, we've done three feasibility studies, two in Europe, one in the US, out of University of Pittsburgh, with Yossi Martel, who's a wonderful doctor and surgeon. If anyone's in Pittsburgh, he's the guy to go to. Um, and they just completed the pivotal trial, the 1 year primary endpoint of the pivotal trial in Europe, and I'm going to go over those results. So let's go over that, and I can talk more about that. Um, it's not approved anywhere, so there's no price set for this device, and that I'm sure will be a negotiation between the company and insurers and all that kind of stuff. And fortunately, is far above my pay grade. But since it's still in testing and not approved anywhere, it is not for sale.
Mhm. Perfect. Um,
Oh, is it removable? We haven't removed it in any patients yet. We have done some animal studies that suggest you can remove it and exchange it as we come up with later generations of implants. Um, but we've never had to remove one in a patient. And again, the post-mortem data didn't show those chips were real socked in, so I think it would be removable. Um, but we haven't done that test yet, or we haven't had a need to remove one in a person, and I don't think we'd just kind of go in planning to remove one and signing them up for an extra surgery. Um,
sure.
but we don't have anything to suggest it couldn't be removable, if that's, makes sense.
Why don't you go back, Frank, and show us that video again with a little bit more verbal description of it,
Okay,
and then we have more questions coming in, and we'll take them as
sure.
the next break.
Okay, I'm going to do my best to keep up with the video. Okay, guys, let's see how I do here. Okay, here's our fancy logo. So here's a picture of the retina, right? And the outer retina just disappeared, and that's to show the atrophy. Here we're going to show the surgical procedure. There's a light pipe going in the eye and the vitrector. It's removing the vitreous, that central gel in the eye. It's now creating a bleb, elevating the retina to make space for the chip. This is the injector for the chip, and it's this tiny 2 by 2 millimeter chip. You can insert it underneath the retina using the custom injector. And then what you do is you want to flatten back down the retina. You don't want your retina detached. And then you have to nudge the chip into that very central part of the macula where the atrophy is. So now it's sitting underneath the retina, directly in contact with those bipolar cells. So here's kind of a patient view, and you see that dark area in the vision. And now when they put on the glasses, the camera's taking the image, stimulating the implant through the projector facing the patient. The infrared light's hitting the chip, which is then stimulating the bipolar cells and sending the signal up to the ganglion cells and into the brain. How'd I do?
I need to turn my microphone back on.
Yeah.
It was great. You did great. That was
Okay.
fabulous.
Here we go. So here's a picture of the equipment again. And so just remember on the glasses, there's both an outward facing camera and an inward facing projector, this kind of infrared light that will stimulate the implant. Okay. So now I'm going to show a surgical video. So this is real-time surgery. Let's see if I'm smart enough how to pause this thing so I can kind of slow it down as I talk here. So what you're seeing here is this called heads-up OCT. So this is what we see in the microscope. So this is the surgical view here on the left. This orange thing is the retina, and you can see the vessels kind of more clearly here. That's where the geographic atrophy is because you've lost the outer retina. Okay, so this is your geographic atrophy area. And then there's this digital overlay, and what that's doing is providing a real-time OCT or optical coherence tomography that's giving this nice cross-sectional view of the retina in two axes. And that's very helpful, and you can imagine when we do this step where we're inserting the chip subretinally, we want to make sure we're in the right plane. We're talking about 50, 100 micron planes. So you'll see next, I'll play it. This is Dr. Martell out of Pittsburgh. He's going to create that bleb by injecting some fluid underneath the retina. Let's see here. And we'll see it. There it is. Here's a little tiny 41 gauge infusion. And he just touches it and creates this little fluid bleb right next to the area of geographic atrophy. Okay. And so now you can see on that OCT, right? You can see that the retina is lifted up. It's attached here and then lifted up over here. Tells him he's got a good bleb. And so what he's going to do is open up that bleb area as a means of inserting the chip underneath the retina. So he's making a small incision in the retina. And here he is inserting that chip. Okay, you see the little chip here at the nub at the end here, and this is the area of geographic atrophy, right? And he wants to get it right in there. Or no, sorry, pardon me. That wasn't the nubbin. That was him just dissecting it open. Here comes the actual chip. Pardon me. So now he's made an incision on the side wall. I hope no one's too squeamish in this audience.
Was making all sorts of noises. Pardon me. I just looked to see that woo, yes.
Okay, so there's the chip. Now, you guys, I'm going to pause it here. You guys see this? The chip here is in the area of geographic atrophy. Okay, he's put on the chip, and now he's starting to put down this little fluid bubble. You can see the bubble here, and that's what's flattening the retina back down. Right? Now he's going to close up the eye wall, and there's our chip. He's just kind of nudging it, making sure it's just in the perfect spot. He's going to dry up the retina, and you either put oil or gas in at the end of surgery to hold everything in place as the eye heals. Gas will go away on its own. You breathe it out on its own over a couple weeks. Oil, you come back in and take it out. It's kind of a minor procedure. But there it is. And this is here he's putting in that oil. And now you can see, oh, hold on. Let me go back here because I like that picture at the end where you can really see it on the OCT. There it is. Let me go back here. Sorry, guys. Bear with me. I bet you figured out by now I'm not a tech guru despite living in San Francisco. Here is the PRIMA implant on OCT. You can see it nice. It's just sitting underneath the retina here. And you can see it in real time here in a surgical view. Did a beautiful job on the surgery. There it is right there. All right. Any questions on the surgical implantation or anything like that?
No, not necessarily, but let me just ask these two questions now, Frank. The first would be, where would the PRIMA be placed in a CHM patient? Many of us have little islands of central vision. Does the implant block the CHMer's remaining central vision?
Yeah, so you would never want to put it in an area where there is healthy outer retina. So you wouldn't want to put it in that island of central vision. I think we'd have to think long and hard about the right way to deploy this in choroideremia. and how to really get the most benefit. One thing that has not been done, but we are interested in exploring next, is tiling these implants. Right now, we're only putting one implant in a patient. But there's nothing, if you had a big atrophic area, the way choroideremia patients have, or these patients with really bad macular degeneration, is you could put multiple implants in. There's space for a bunch of these things. And because they're totally wireless and kind of independent of each other, there's nothing to say you couldn't tile out a huge number of them to create peripheral vision, as long as you could get some light to those areas to stimulate the implants.
Mhm.
Um, so I think that could be a really big opportunity where if you had a choroideremia patient that had that tiny little central island, you could almost put a ring of these things around that central island to expand that island back out. And it would almost be the inverse of the AMD patient where, you have the prosthetic vision centrally and natural vision peripherally. In the choroideremia patient, you have the opposite. You would have natural vision centrally and a ring of peripheral vision, um, or a prosthetic vision peripherally. Um, but that requires some study and consideration. We're not going into choroideremia patients right now. I think that's going to be a future endeavor. But obviously will require some deep thought and probably some modifications to the approach.
Sure. And someone asks too, will this work with no side vision?
I think that's something we can figure out. Right now, with the current generation, I think it will be very challenging, again, because you want to be able to localize the light from the projector right on the implant. And I think having some side vision helps you kind of make sure your eyes are lined up perfectly to that projector. It projects, I think, about a 4 or 5 millimeter wide beam of light, and your implant's 2 millimeters. So with only one implant, it's a pretty tight kind of lineup. Um, Future products we're looking at are developing an eye tracking system built into those glasses that can help adjust where the light goes based on where your eyes are looking, so you don't have to do as much of that. But I don't have a slide on it here, but one thing the patients have to do is a huge amount of training after they get this implant to learn how to line the thing up and line everything up. It's tens of hours of training, and some patients even hundreds of hours of training, and then it's ongoing. So right now, I think with the current technology, the patients really do need some of that peripheral vision, which is why I think the applicability to choroideremia at this stage is limited. Um, but as I mentioned, I think we have some good strategies in the future to make it more applicable and more useful to this population.
We have some more questions. I can give them to you now, or do you want
Sure.
to
No,
continue
no,
in
no.
the
Let's
chat?
just go. I'm happy to, because then we're going to kind of switch gears and go through clinical trial data. So
Okay. How about the first one is, are you doing one or both eyes right now?
we're doing one eye right now. Um, and the reason for that is, a lot of this is kind of single reading tasks, and a big advantage of having two eyes is binocularity, right? 3D vision, stereopsis. And it's not clear that you would get that from having one of these in each eye. Um, and so because the implants are kind of digital, and we could probably think our way through it, but for now, certainly one eye. Also because it's in a clinical trial stage, and you want to always be able to compare the eye that had the procedure and surgery and the implant, and the other one that was kind of the control and didn't have anything happen to it.
Sure. Here's another question. Are anti-rejection medications needed?
Hmm. That's a great question. No, they're not. We just give the standard post-operative eye drops that you would give after any vitreoretinal surgery. Um, we were not seeing any things related to the device requiring anti-rejection medicines or any special things related to the device.
Okay.
I'll show you all the safety data from the clinical trial results.
In the video that you showed, there was a clock, right? That the patient looked at. Is that what the image would look like?
Yeah, I'll show a video in a second of kind of exactly what the patient sees, or at least our best representation. That was just kind of the animation one. But I have a patient video in here where you can see exactly what's being projected onto the chip. So we can't tell exactly what they're seeing, but you can see the image, the black and white image that's being projected onto the chip.
That'd be awesome. And when that happens, Frank, could you just like verbally explain that too for our folks?
Yes, 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 yes.
Okay, here's another one. What are the and you again, you can incorporate this at the end if you like. What are the plans for future Prima generations?
Yeah. So a couple things that I think are the close in next steps. One is improving the glasses. right? And figuring out a way to make that with eye tracking and ways to make it more ergonomic, maybe get rid of that pocket processor. I think there's a lot of opportunity there in technology. Um, I think for the actual implant, Dr. Palanker has shown some beautiful animal studies showing he can get a much, much smaller size pixel. Um,
Mm,
and to think of it just like your TV, right? The bigger that pixel is, the less resolution you have. As you start getting smaller and smaller pixels, the higher resolution. So right now, the pixels are about 100 microns, and he's published papers showing up to 30 microns of size, which, if you think of it theoretically and do the math, that's like 20/50 vision you could be getting from that, which is very exciting.
mm. Just two more here. Just to verify, because of the chip, it opens up access to digital devices that can send images directly to the brain, bypassing the CHM impact areas or blind spots. True?
Yeah, so we haven't, right now, the only device that it interacts with is the glasses that are part of the PRIMA system, right? So just those glasses are just taking what's on the camera and sending it in, or in the research setting, we can send things directly from our research computer onto the implant. But I don't think it takes some huge leap of imagination to imagine that, you could have your computer monitor projected in there if it could talk to the thing. We certainly haven't done any of those things, but you could imagine that that's not some huge technological leap. Does that answer the question?
I think so. I think so. And Mike, if there's more to that you want us to ask, just go ahead and write back. And the last one, then we'll let you continue. This is a gentleman says totally blind, but lots of light flashes, diagnosed with choroideremia in 1965. Would this kind of patient work?
Um,
Again, yes, go
Yeah,
ahead.
hard to know. Again, with the current technology, we're really finding that peripheral vision is very helpful for the patients. But hard to know where those light flashes are coming from and the status of the retina. So I think it would really depend a lot on that. Again, all the trials right now, as of today, are on geographic atrophy. But as I've mentioned, there are a lot of analogous things about the physiology and anatomy in geographic atrophy that would work well with choroideremia in the future.
Let's go.
Okay. So, as I mentioned, there have been two feasibility studies, and then the pivotal study. The first was a study in France with 5 patients. And I won't read these slides entirely, but several year follow-up, first implantation in 2017. So I guess we're a little bit less than a decade. What is that? 8 years was the first implant. So we're 8 years out, pardon me. Um, Patients with very, very poor vision, 2400 vision, in five patients, and we just want to see what they could see with this implant, right? The first time ever. Then in 2020, we implanted 4 subjects in the United States with 3-year follow-up. Now we're starting to look at acuity. And we just completed the 1-year endpoint of the Primavera study, which was the pivotal study in Europe. And I'm going to go into some detail on that. Now we're talking about 2300 vision, and really want to see if these patients can read the impact and a lot of safety. So we haven't finished the trial. It's a 3-year trial, but we finished the 1-year endpoint, which was the primary endpoint. So let's dive into this. So these are the first France patients. And you can see the implant sitting on the patient's retinas, okay? Um, Obviously, this is well within the geographic atrophy. This one is not totally aligned, right? So here's some challenges in the surgery, but these other ones sat nicely. And it turns out this patient actually still had excellent perception from the implant. Um, and so now I want to show you some of the patients from the Primavera study. So if you look, this is that computer. I'm just going to pause it here for a second. So if you look on the left side here, there's a little digital display on the computer. The left side is what the camera's picking up, okay? And you can see the book this woman's reading, and you can see the letters. It's kind of zoomed in here. Was be something employed. And then what it does is it processes that, makes it very high contrast, and turns it into the infrared signal. So this, in this circle, you can kind of barely make out this circle here. I'm outlining it with my mouse, is what exactly is being projected onto the implant. Okay. And again, I apologize. I'm not sure if the audio from this video is coming through, but what you can hear is this patient reading for the first time. She hasn't been able to read before since her geographic atrophy advanced, and now all of a sudden she can read this book slowly, She's not reading sentences, she's seeing a whole sentence at a time, but she's able to see groups of letters at a time. And as she scans through, she's reading. So it was a very exciting result to see for the first time. Right. So there's the view through the glasses, the image sent to the implant. Exactly. And then here's another task. This is playing cards. And you can imagine playing cards with low vision is incredibly difficult. And you can see on the computer monitor here, see if they'll zoom in, you can kind of see what she's seeing in real time. And you can see the cards. Like there's the king. And she's able to identify the king and play. I think they're playing Go Fish or something. Over there. And here's one that's really impressive. You think about a challenging task, it's filling in a crossword, because you not only have to know what letter you want to put in, be able to read the thing, but then you have to draw the letter in this very small box. So this was a patient that was now able to do crossword puzzles, which was very exciting. I apologize. I'm not sure how well this stuff is projecting over on the webcast. These videos are actually available on YouTube. We've anonymized them. And so if you go on YouTube and just search, PRIMA implant patient videos, you can see all these videos and take your time with them, but they're really, quite impressive.
That actually, Frank, was a question that just came in. Are these available to get online? So
Yeah.
can you just say that one more time?
So
Where to find them?
yeah. So if you go on YouTube and you can just do PRIMA implant patient videos, or if you go to the Science Corp website, which is science.xyz, and you click on the PRIMA thing, I think there's a link right to these videos. And I'm happy to send these to you afterwards. And you can send them out to anyone who wants them.
And you know what, guys, we have actually sent them out to earlier with the registration. So if you don't have any success or have a hard time finding it, just email Corey or myself, and we'll be able to get those to you.
Yeah. Um, so these were very exciting results to see, some of these patients respond in such a way that they were really able to regain tasks. And the resolution with the device is one thing, but the idea that there is a blind piece of retina that cannot see and being able to now put an image on there that can be interpreted, I thought was, really got the ophthalmic community very excited. Um, so here's that feasibility study. Patients, what we do is this ETDRS letter chart. It's where the letters are kind of all the same size and you bring them down in rows. It's a good way of measuring vision in clinical trials. And so patients, gain on average 32 letters. So that's about 6 lines of vision versus their baseline. Okay. And so here are the chips. And you can see the implants are sitting nicely underneath the retina. This is just to show there's not a bunch of retinal loss overlying the chip. There's not a bunch of swelling. I know this is kind of a scientific photo, but this looks good. Gonna take me at face value on this one. It's the retina is not getting beaten up over the chip, which is obviously one of the things you want to make sure of. So based on these feasibility results, we went into the pivotal trial. This was conducted in Europe. It was, non-randomized open label. Patients knew whether they were getting the implant. Enrolled 38 patients, and the requirement was they had to be older than 60 years old, but as you see, they're almost 80. They need to have an area geographic atrophy that was big enough to accommodate the implant. So it was about 5 millimeters squared. And the vision had to be 320 or worse. Because you need to be able to get benefit from the implant, right? So if you have good vision, it's not going to do much for you. So if you had really crummy vision, this could make a meaningful improvement. And then we had visual endpoints for this. Okay. So here are all the places we did the trial. These cities across, I think, 5 countries in Europe. Average age, like I said, is about 79. Pretty evenly split between men and women. Most people had been diagnosed about 10 years prior with AMD. And if you look at that mean atrophy size, to get to that level of vision, they had pretty big areas of atrophy. It's 25 millimeters squared. It's basically the entire macula. Okay. So let's look at the results. So this to me is the most impactful. Without PRIMA, nothing changed, right? And we didn't turn the device on. Vision stayed stable. This is about 2300, 2400 vision. And it tells you that the vision isn't damaged by the implant, which is good. Now let's turn on the implant as the red line here. and you see a marked improvement in ability to read letters. Now, remember, the asterisk on these results is that we're taking full advantage of the electronic processing the device offers. And so the patients were able to zoom in, zoom out, play with contrast, play with all that stuff. And so that enabled them to read smaller letters. Um, but what was interesting is a lot of patients didn't find that just magging up all the way was helpful. What they like to do is kind of have an intermediate magnification and then kind of scan with their eyes, and they could actually read the best with that. Um, so here, this is equivalent in Logmar. We don't use it as much in the U.S. The Logmar, the Snellen equivalent for that is about 2140. Okay, and at baseline they're about 2300, 2400. So really a dramatic improvement in their vision and ability to read.
Hey, can I ask you a quick question that's really pertinent to the area that you're talking about now?
Please.
Does the brain need to be trained to recognize the implant signals?
Yeah, and it's so interesting, and we're just starting to kind of parse that out now. Is patients the prosthetic vision isn't clear initially to patients, and then we do all this rehab and training, and then
Mm.
it starts becoming very clear to them, and we're trying to understand what that tuning process is, because I really do think there is a tuning process where the brain kind of acclimates to prosthetic vision, incorporates it, knows that what a straight line is, knows what a letter, but there
Mhm.
is that learning phase, and it kind of happens coincident with them learning how to localize the signal from the light and all the other processes that are happening. But I was just talking about this with one of the researchers on the project, is that when you have patients when they very first get the implant, what they describe is not the same. Even if they're looking at the exact same thing, the letters aren't quite as formed right at the beginning, and then they start getting much, much more formed, and then to their final, visual acuity. But there is some tuning process that we don't understand. But you know, it's great that they're able to do it, and especially in older patients, right, that have been using their brain to interpret visual data one way, one way for the last 80 years of their life, can all of a sudden, within a few weeks and months, totally change the way their brain can interpret visual data. It just speaks to the
Yeah,
incredible neuroplasticity.
it sure is.
Um, so just to kind of move out of that Logmar paradigm, kind of, I always find for myself and for U.S. audiences, this makes more sense. The mean improvement was 5 lines on the chart. 5 lines smaller vision, and the results were not homogeneous, right? Some patients had a little benefit, some patients had a lot of benefit, and so the patients that had the greatest benefit, there are almost 12 lines of improvement. We had a patient that was seeing about kind of on the order of 2060 letters using the implant. So it's quite incredible. Um, the main endpoint was saying what percentage of patients that got this implant improved by 2 lines or more, and so that's 10 or more letters, um, and that's 81% of patients that got the implant and improved by 10 letters or more. And so you can see almost 80% had great more than 15 letters. Um, there's about 20% of patients that did not get much bang for their buck out of this thing. Um, I think we're still sorting through who that is and why that is. Obviously, the ideal would be to identify those patients who it's going to really benefit and say, hey, let's do this for you. And the patients that it's not going to benefit, say, hey, this isn't the right technology for you. And as we go through all the data, as I said, this is pretty hot off the presses. As we go through all the data in granularity, trying to understand who this 20% was and why this wasn't as helpful for them. Certainly, some of it is in the amount of training folks are doing. That like I said, that at-home training is pretty rigorous. And if you're not doing it, it seems to be a little bit of a perishable skill that if people are not using the implants enough and not doing the training enough, they don't see as well. Versus the patients that are using a lot or doing the training are seeing better. And it's to some extent it's a virtuous cycle. Obviously, if you're doing it a lot and you're seeing better, you want to do it more, and kind of progress from there. Um, just some kind of subjective things. 84% of patients said they were now able to read letters, numbers, or words, whereas they weren't before. And about a third of them said now they could read in a dimly lit environment, which they couldn't do before. So that was really encouraging as far as like really concrete things that enabled these patients to do. Um, this again is showing safety and just saying that, hey, the study eye, which is this green line here, if we don't use the device, is your vision hurt? Is your natural vision hurt in any way by putting this in the eye? And this thing is rock solid stable and shows it really wasn't changed at all. And similarly in the non-study eye, right? Was there any fellow eye effect? There was no fellow eye effect. So there were, in any surgical study, you're going to have complications. Um, there was 8 retinal breaks that were treated during the study. Um, Hypertonia is just high intraocular pressure. Um, I think it was 90+% of those were during, an immediate postoperative period, and that's not uncommon with retina surgery to have patients with high eye pressure afterwards. One thing you worry about in any time you're doing subretinal surgery is bleeding in that area. And so there was bleeding, as you can imagine, we're putting that chip in there, pushing it around. We did note bleeding in 6 patients. Um, that bleeding did not affect the final study results. Generally because the bleeding was in an area that already had atrophic retina, right? So the retina was already kind of damaged in that area, and that's why we were putting the implant in. So when there was bleeding there, it didn't affect much. Um, 2 patients developed what's called choroidal neovascularization, or CNV. It's the wet form of macular degeneration. Hard to know if that is from having an implant in there and doing surgery versus just kind of the natural rate. You see about 5% of people or so with GA, even if you don't touch them, just natural history, develop wet macular degeneration per year. And so eh, hard to know if this is from the implant or this was just this kind of our 5% natural progression because it's in line with that. Um, one patient did, I would say probably the most serious adverse event was one patient after surgery developed a retinal detachment with proliferative vitreoretinopathy, which is scarring of the retina, and required several more surgeries to treat the retinal detachment. That certainly is a risk with any retinal surgeries. And in the spectrum of retinal surgery, this is a more significant one. So the retina's back attached, patient seems to be doing well, but that was probably the most serious complication, and there was one of those. Um, so that's kind of what I have for slides. If I'm thinking about conclusions, I think for the first time we're seeing restoration of vision in an area of scotoma, where you've totally lost your photoreceptors. There's no vision in the area of the retina, and now there's a technology that I'm very excited about that can bring back form vision. Reading letters, numbers, things like that. Um, how we expand on that and get that resolution sharper, increase the size of the area of resolution, um, is what we're going to continue to work on. We are working to get this device approved in Europe right now. And next, we are working with the FDA on seeing how we can bring this device to the United States as well as along with other countries. Um, and that's where we are. So thank you guys so much. I'm happy to answer any questions you have. Oh, and these are all the people, these are all these excellent doctors that were involved. I was not an investigator in the study.
Mm.
But these are all these excellent investigators and advisors who've been, working on this thing for years and years.
Do you know a couple questions? I gotta adjust my camera. Do you know, Frank, what is the timeline of taking it to commercialization over in Europe?
Um, so, I know they're working on submitting for CE mark. I don't want to speak out of school and put a specific timeline on it, but I know there's plans to submit, in the very near future for the actual CE mark.
Excellent.
And then it'll
And
be up to the regulators for how long it takes.
do you have any description from the clinical trial patients about what it was like to see facial recognition, or the movies that we saw were awesome, but what was it like to try to identify different people?
That's a great question. I don't know. Let me follow up with that because actually that's a really good question. I don't know. I've seen they have a couple of videos I've seen where they're out in the wild, kind of going to cafes and at bus stations, reading the schedules and that kind of thing. But I actually have not seen any ones where it's raw facial recognition. That's a great question. Let me ask the European guys.
Perfect. We do have some more questions coming in. Somebody asked if this will be shared, and our discussion today, our webinar, will be sent out to the foundation. So you'll be getting that probably tomorrow or the next day. Now, I think you touched on this already, but someone's asking again, is it feasible to have a larger implant? I think that was about the mapping that you discussed.
Yeah, so there's the question about whether we can tile multiple implants or just create a
Mhm.
larger implant. Um, each has pros and cons. You can imagine that with a larger implant, you need to make a larger incision size, depending on the shape. And generally, smaller incisions are better in any part of the body, especially the eye. Um, And so, but obviously it's easier just to put in one implant than put in, more. So it's something we're working on and we're figuring out. This is clearly, kind of our first generation attempt at it. And it's an area that we know we want to work on.
It's so exciting. It's really exciting.
Thank you.
Another question is, of course, we always want to, if we can make things faster, when would it be available? Is there an opportunity to fast track it? What I would say emergency use designation. Is that something that we could possibly, or the entities would ask the FDA to do?
I think that's great. And one of the things we're exploring now, both internally and with the FDA, is the right pathway for this device, and to get it to patients in the United States as fast as we can. And to that end, we might call back to you guys and say, hey, listen, if this is interest to your population, maybe you can help us in supporting, talking to the regulators and saying what a meaningful impact this could have, for patients. Because I know they love to hear from patients directly, and there's only so much we can do as kind of the applicants.
And I'm sure we'll be able to do that. We have a great advocacy group here as the foundation. We already have done that a couple different times, and I'm sure we can do that again.
That'd be wonderful.
Absolutely. Here's more questions coming in. Apologies if this was already asked, but once implanted, is there forever, or can it be replaced with the next gen version?
Yeah, I think that question's spot on, and it's one of the things we certainly think about when we're thinking about putting this in younger patients, right? Um, as I was saying, we don't have any signals to suggest that it can't be replaced, both in our postmortem studies and our animal studies, but we haven't done that in a person yet. Again, a huge advantage of our implant is it's totally wireless. I think some of the other implants, just think about the Argus, things like that, they're wired implants. They go to battery packs. They have all this other stuff. This is just a single free-floating chip. So what we've done in the animal studies is you just lift back up the retina, just the same way we did the surgery, pop one out, pop a new one in, and we've done that in animals. But we haven't done that yet in humans, but that would be, kind of the plan.
Yeah. Um, Results in training. Are there any variants or analysis-based patients? Let me start again. Results in training. Any variants or analysis basis patients based on nationality or customs, if married or living alone, and any comorbidity with dementia?
Yeah. So patients with diseases like dementia were excluded from the initial trials, because we knew that would be tough. That granularity of detail, is going to be talked about in some publications we're working on, but the data is embargoed for right now. So I can't go into that level of detail. But it's definitely something we're working on in great depth, is to try and understand exactly who got the most benefit from this. So we could kind of say who we're calling the super users and figure out what characteristics made them very successful in using the device, and figuring out how we can expand that or broaden that population.
The CRF is going to keep tabs on this, and we'll update our members as we receive them. Can people also go to clinicaltrials.gov and put in science prima or the device, or how, to the extent of what you were just asking about, how can we follow up with those papers that are going to be published?
Yeah, so probably the best source right now to get the most up to date is actually through, if you go to the Science Corp website and they have a news link, it's science.xyz is the website. Um, and they are very quick to publish kind of up to the minute releases, publications, clinical trial data, all that. There's a PRIMA section that gives a whole overview, a very nice overview of the technology and the trials. But then also, as soon as things kind of come off embargo or we're allowed to say things by regulators, we put it up there pretty much same day. So to follow this, that's the best way.
Here's more questions about that topic. What is the time frame to consider inclusion of additional disease states such as CHM in a trial?
It's a really good question. I think we need to get our first indication across the goal line. I think it's much easier to open up, to additional disease states once you have your first approval and you can really show safety and everyone kind of agrees this is a safe device. And so I think a lot hinges upon those first approvals in AMD. But we are actively talking to some sites, and I can't go into a huge amount of detail outside the United States, looking at other inherited retinal diseases and possibly trying to get some of those patients enrolled in the very near future.
Next question. How does PRIMA tie into science's overall strategy?
It's a great question. So Science is a neural interface company. They do a lot of brain machine research and work, and I encourage you to check out their website. It's incredible that it's every time I go to a company meeting, I'm obviously deeply just in the PRIMA section and not aware of too much of what's going on in the rest of the company. But when I go to these company-wide updates, it's like sci-fi. The stuff these guys are doing, it's unbelievable. How they are getting creating brain machine interfaces. And very, very exciting. It's a lot of the folks from Neuralink are founders of Science. And so a lot of the things along the same vein with some different approaches that you can check out on their website. So this is an extension of that. This is bringing a sense and you know, in a sense, it's brain-computer interface, right? It's your brain and digital vision and restoring sight for people. Um, but yeah, I really encourage you guys to check it out. It's super cool stuff. Most of it's over my head, but I think you got a lot of smart people on this webinar that'll figure it out.
Wow, I'm just doing one more check. No more questions coming in. This has been extraordinary, Frank. Thank you so much for your time and your dedication to this area. So many of us are grateful for everything that you guys are doing.
Oh, absolutely, my pleasure. Thank you so much for having me. And if there are any other follow-up questions, just send me an email or something like that. I'm happy to get back to folks.
We'll make sure, folks, that when we send out the recording, we'll make sure that we send Frank's contact information. Is that okay? Just email you directly?
Probably come through you, so it's aggregated a little bit. I think that would probably be the best.
Okay, perfect. We'll do
I don't
that.
want to miss anything, you know?
Two other quick points, everybody who's still on. Wanted to just let you know we are having a webinar tomorrow night at 8:30 Eastern on family planning. What are the choices that we have? We have one of our own CHM carrier daughters who is also a geneticist. So she's going to be joining me tomorrow night. If you're interested, I think there's an invitation out. You can join us that way. And then lastly, one of the things that we're starting to incorporate, just as a reminder to everyone, we are entirely operated by charitable donations. So if you enjoyed this webinar or the ones that we've had before, consider making a contribution to the Choroideremia Research Foundation at curechm.org. Every penny counts to do just the stuff that you're doing. So thanks, everyone. Frank, stay healthy, stay well.
Thank you. Appreciate
All
it.
right.
Thank you.
Thanks,
Bye.
everybody. Have a great night.